All too often, those with severe mental illness have physical ailments that often go undiagnosed or untreated. Joining us now for more on the efforts to change health outcomes for those with mental illness, there's Dr. Sanjeev Sokalingam. He is Director of Curriculum Renewal with the Medical Psychiatry Alliance. He's also Deputy Psychiatrist in Chief at the University Health Network, and we're happy to welcome you here to TVO tonight.
Thank you.
Let's just put some of the background up first before we chat here, Dr. S., as everybody calls you, I understand. The Medical Psychiatry Alliance was established in January 2014 with a $60 million grant. $20 million of that came from an anonymous donor. That's a good start. 1.3 million Ontarians have both a mental illness and a physical condition that they deal with as well. And partners in the MPA include the Centre for Addiction and Mental Health, the Hospital for Sick Children in Toronto, Trillium Health Partners, and the U of T. So with all of that background in place, tell us, what's your mission?
Well, our mission is really to respond to a system need. As you know, Steve, there's a growing concern about mental health in our system today. There's, as you stated, a growing burden, especially in Ontario here we've seen, in terms of people living with both physical and mental health conditions. And the Medical Psychiatry Alliance, also known as the MPA, has been formed to truly address some of that burden in terms of physical and mental health and transform models of care or programs of care to provide better access and health quality and care outcomes for patients and families.
When do you think the health profession writ large started to realize that this combination of problems was a thing that had to be dealt with?
Right. I think this is something that's emerged over time. I think as we've seen many mental health conditions evolve over time, follow patients longer, have newer treatments. Some of these treatments, some of the conditions have led to greater recognition of the physical health burden in our patients. And with that, I think we've seen large-scale studies showing shorter life expectancy for many of our patients with especially severe mental illness.
Hold that thought right there, because I got numbers dealing with all of that right here. This is MPA numbers from a colleague of yours that works out of CAMH. 5-year study, 72,000 patients who had schizophrenia and had just experienced a heart attack. The risk of death within 30 days after discharge from the hospital was 56% greater for patients who also had schizophrenia versus those who didn't. And patients with schizophrenia were 50% less likely to receive a cardiac procedure or follow up with a cardiologist compared to individuals without schizophrenia in the 30-day post-admission time. Now, I mean, the obvious question here is, if you've got mental illness, why are you not getting the follow-up care that people who apparently don't have mental illness but also have heart problems do get?
Right. This is a huge concern and one of the mandates for the Medical Psychiatry Alliance. I think this study is one of many studies that show that patients or an individual suffering from severe mental illness do not get the medical care that they need. And so the question you ask is probably multifactorial. I know that's a common term in meaning that multiple factors here, but I think there are specific patient factors and provider factors that play into this. One is definitely that individuals with severe mental illness may have difficulty attending appointments and following up with care. Interesting, in the study by my colleague Paul Kurdiak, who's the Director of Health Outcomes for the MPA, in this study, these were patients who are actually in the hospital, and most of these procedures are delivered in the hospital, so they're not coming back, and yet we still see these gaps in care, which is quite profound. And so then you ask yourself, why is that? How could that be if they're still in the hospital? So part of this is likely lack of knowledge or team-based care that can provide that more comprehensive care to manage both the mental and physical health conditions.
Well, can I hit it on the head a little harder? These patients are harder to deal with than other patients, and therefore doctors probably, and to a certain extent understandably, don't want to have to deal with them. Is that fair to say?
I mean, I think there's issues potentially of stigma that we see in mental health. I mean, we've come a long way, but there's still a way to go in terms of stigma in mental health. And difficulty, absolutely, in terms of managing care and people feeling prepared enough to manage patients with this kind of complexity in our system.
Okay, so schizophrenia is obviously a more significant condition than, say, well, I shouldn't say this we should ask you, what if it's depression? What if it's not schizophrenia, but it's depression, which may be, under certain circumstances, easier to treat than, say, schizophrenia is? Do you see the same kinds of double standards within the healthcare system?
Well, I think there's great evidence that we have emerging treatments for depression, for example. But when we layer on top of that physical health conditions with depression, we see challenges in treating both simultaneously. And so a good example would be cardiovascular disease or heart disease and management of high blood pressure, cholesterol, diabetes in someone who's depressed. And in those conditions, we have higher rates of depression, but having a depression impacts your physical health outcomes. So you're more likely to have abnormal blood sugars, you're less likely to get your cholesterol under control if you have active depression. And there are a variety of factors. It could be difficulty in dealing with depression, recognizing depression. It could also be when people are not having access to treatment for depression, for example. And we know if you're depressed, it's hard to be motivated to stick to appointments, to adhere to things. And also, there are biological mechanisms that also play into these factors as well.
But generally speaking, I mean, we've been very focused, I mean, the system is very focused in our coverage on this program. We've been very focused on mental illness and, strictly speaking, what it does to your mental abilities. We have not really focused as much attention as what mental illness actually does to your physical being as well. So is it fair to say, generally speaking, that if you're suffering from a mental illness, you are probably going to have more physical maladies than the average person as well?
Absolutely. And so, again, if you take one group, maybe if we look at serious mental illness, for example, shorter life expectancies, greater cardiovascular disease, cancer, for example. But if you look at even depression, there's people with depression have higher rates of diabetes, and people with diabetes have higher rates of depression, this two-way relationship that goes on. And so I would say, mental illness is a risk factor. A great example of this would be recent research that also came out of Toronto as well, in collaboration with other international colleagues, that showed that in teenagers who were depressed, right, or who had bipolar disorder, they're more likely to have cardiovascular disease or obesity, high blood pressure, cholesterol, and that's regardless of the treatments that they were on.
Well, I guess if you're dealing with mental health issues, the notion that somehow diet and exercise would be high priorities for you may not be there.
Absolutely.
You've got bigger fish to fry.
Absolutely.
Metabolic conditions. Is there a connection here between that and the issue we're talking about?
Absolutely.
How so?
So I think one of the things that we recognize is that metabolic conditions, again, have that bidirectional or two-way relationship with mental illness. I think many people are aware that some of the treatments, especially for some mood disorders or schizophrenia or psychosis, antipsychotic medications, particularly the newer ones, have higher rates of obesity and metabolic disturbance like diabetes. But we also know that in people who are not treated or with these antipsychotics also have a higher rate of these conditions as well. So there's something in the disease in terms of biological mechanisms, lifestyle modifications that you've talked about, but also the medications as well. And so we need to take into account these factors when we're treating someone in terms of these holistic type of models of care.
If I'm dealing with a mental health issue and I have, as a result, physical maladies that come along with that, how much less likely is my lifespan compared to a regular fit? I shouldn't say regular. What's the expression I'm looking for here?
So someone without those conditions.
Someone without. Okay, good.
So I think we have great data for people who, for example, have a serious mental illness like schizophrenia, that the life expectancy is 20, maybe even 25 years. There's recent data that it's increasing and getting worse. So despite all this public health effort, despite a recognition of these risk factors, we're still not making a dent in terms of trying to improve life expectancy for people who are suffering the most from mental health conditions.
Before your alliance came along, how were medical professionals trained to look after mentally ill people?
So before this, I would say oftentimes, if we look at medical school, for example, we have blocks in curricula or courses on psychiatric illness that are integrated throughout in blocks in their first 2 years in classrooms. And then in their clinical years, the third and fourth year, they get about, in Toronto, it's 6 weeks. In some parts of North America, it could be as short as 4 weeks of mental health or psychiatric care exposure or training.
Was that adequate to the task?
Well, I'll leave that in the numbers because I do think that that's something to consider. Is that enough? And maybe these short bursts, are they enough? Is that how we learn about mental health conditions? These are often illnesses that are not short episodes of care, right? They're someone is suffering from depression or more severe psychiatric illness. They're probably having these conditions for a longer course. They're getting relapses. So are we really teaching our students how to treat these conditions adequately?
If you're a GP and you've got an office and you see patients, what's the likelihood you're going to be running into somebody in that environment who's dealing with serious mental health challenges?
Well, I think the rates are quite high. I think our family physicians are dealing probably with most of our patients with mental health conditions in the system. Because I think in general, if you look at the average patient, they're not coming to psychiatric care. I think you've had on your show before issues about access to mental health care in the system,
Sure.
and challenges with that. And so we know that probably the family physician is probably the point of care, and we're seeing a lot of these patients. I think the challenge is having adequate integration of mental health services for those more complex and kind of co-managed type of situations.
Well, let me hit it on the head a little harder again. You know, if you're a doc, you're a family doctor, you run an office, there's nothing that obliges you in our healthcare system to see people who've got mental health challenges, right? So what do we do about that?
Well, I think that's part of the mandate for the Medical Psychiatry Alliance. I think we're looking at patients who have mental health and physical health issues, and that includes the serious mental health issues, and those might be in psychiatric type of settings. We're also looking in medical settings and primary care. And so if you're dealing with individuals who have both and are having these complexities, it's obviously a huge challenge, right? This is not an easy task, right? And sometimes with the volumes of care, the pressures, that this can be a huge burden. And so one of the mandates that we're exploring is trying to look at new programs and services that make it easier for patients to get to the place that they need to be for these care episodes, and longitudinally. And we also are looking at ways to facilitate access for primary care for these more comprehensive services for these more complex patients.
There's this expression, empathy erosion. What does that mean?
So that means, well, we see that sometimes in medical school. It's been talked about, especially when students come into their medical school training with the intent on helping patients and really understanding their patient's experience. But when they get into their clinical years, we start to see that fade and that erosion to happen. And you know, part of that is how we set up our system and the training environments in that setting. And also the exposures and experiences that they have with individuals, such as those with mental and physical health conditions.
I've heard doctors, I mean, not lots of doctors, but you hear this, you know, they refer to patients as gomers. You know this expression, right? Get out of my emergency room. They don't want to have anything to do with it. And maybe because there's a mental health angle here as well. So is it possible to change the way doctors think about and relate to these kinds of patients?
I think it is possible to change. We believe so in the Medical Psychiatry Alliance. And I think part of the way of doing that is taking a multi-pronged approach to this. So we're starting early in medical school, right? If we can get to students earlier and expand their awareness and knowledge about the impact, as just as we discussed, mental health conditions on physical health outcomes, right? The issues with access and how we might be able to change that. And then in their clinical years, being able to have experiences where they get to see patients through their episodes of depression and their heart disease management, right? And see how if we can treat them together, that they can have better outcomes. I think the other areas that we're also going to people who are practicing and teams that are practicing and outside of, say, medicine, because we know this is not going to just happen with physicians, right? We need to have other healthcare professionals, nurses, occupational therapists, social workers, all engaged in this mandate. And so part of the Medical Psychiatry Alliance is to look more broadly of systems of care.
It takes a village.
It takes a village, yes.
That's Dr. Sanjeev Sokolingam from the Medical Psychiatry Alliance. Thanks for your time tonight here at TVO.
Thank you.
Help TVO create a better world through the power of learning. Visit supporttvo.org and make a tax-deductible donation today.